Okay, I think it's time for our afternoon session. So I appreciate everybody's enjoying lunch and networking, which is so important. But we'll get going with our 1 o'clock session, if that's okay. So we've talked about lots of things this morning. What does the elephant look like? What is it like to live with an elephant? How do we wrangle the elephant? And this afternoon, we're going to talk a little bit about how do we avoid the elephant? How do we not even encounter the elephant? What can we do so that we don't expose people to medications in the medical community that might get them addicted or get them started on a spiral for addiction? So I'd like to welcome Brian Velker and Brian Vidian to the stage. They are both certified nurse anesthetists that work at the hospital doing a pain clinic. So we have Brian Vidian. He's a certified nurse anesthetist who provides interventional pain management, and he completed his advanced pain management fellowship at the University of South Florida, a master's of science nurse anesthesia from Wayne State, and his bachelor's of science in nursing from University of Michigan. When I was reading that, there really wasn't a good team after this weekend, so University of Michigan will have to do. He utilizes a comprehensive approach that includes advanced diagnostic techniques and targeted therapies to enhance a patient's quality of life, promote functional recovery, and improve well-being. We also have a second Brian Velker, who is also a certified nurse anesthetist, also completed his bachelor's of science in nursing at the University of Michigan. He is certified in non-surgical pain management, and he completed his advanced pain management fellowship at the University of South Florida, Master's of Science in Nurse Anesthesia at Our Lady of the Lake College. And Brian's focus is opioid-free interventional pain management, including fluoroscopic and ultrasound-guided procedures. So we have a little panel discussion with some questions, but I thought we would get started by just letting them talk about what it is that they do on a daily basis so we can understand more about that first. We're going to get we're getting a microphone. Thank you.
Check. Perfect. So, Hillsdale Pain Clinic. So, brief history. Approximately 15 years-ish in one form or another in different areas of the hospital. Has seen patients primarily referred in the area for acute pain, chronic pain, pain conditions that last anywhere from a matter of months to lifelong conditions. So long-standing in the community, pretty large referral base, whether it's orthopedics, and just general primary care referrals for mostly chronic pain conditions. Most of what we do on the opioid-free side of things, so there's medicines that we can use that do not hit receptors the same way opioids do. So partially management using those medicines, and then injection therapy. So injections up and down the spine that target areas that are painful, that otherwise are inflamed, that over time with injection therapy can ease pain and slowly heal themselves. Targeted nerve therapy is another sort of thing that we do quite a bit of, where if we find a painful area around the body, be it a knee, hip, shoulder, back, wherever, are there nerves that we can essentially turn off in that area so that we haven't fixed surgically what's wrong with the patient, but we've turned off that pain. So they're no longer on the round-the-clock pain situation that they were, because that nerve isn't sending the signal anymore. So it's kind of overall.
And I would just add that where we tie into this is we see people farther downstream that have at some point in time been prescribed narcotics and have become addicted, and they're using it to manage chronic pain, whereas really most scientific studies have proven that acute pain is great for narcotics, so post-surgical pain, things like that, cancer pain, whereas most of the pain that every one of us here experience at any point in time is not really receptive to the narcotic. What it is receptive to is like if a person takes, say, Vicodin, is the Tylenol component in it. So is what I always say is that, you know, and right now Tylenol is a bit controversial, but I think as we get older, it's a wonderful medication for managing pain, but I'm just using Tylenol as an example. Most of the medications that we take that are narcotics have Tylenol in it. And that's the component that's generally helping with the pain, whereas the narcotic is medicating the brain. So you're medicating pain versus medicating brain. So we've decided in our career path is, and I can just, as a personal anecdote, my father went through this experience, is during the late 1990s, early 2000s, there was this growth in hospital systems for the sixth vital sign, which was pain. And at that time, I was working at the University of Michigan Hospital, and it actually became something that we would chart. Every couple hours, you ask the patient their pain. If they're having pain, we gave them narcotics. Well, obviously, we were foolish to do that, but we were influenced, I think, and you can look this up. There's a couple of really good documentaries about how the drug companies kind of pushed hospital systems and physicians to start prescribing. So that's, for me, I got to experience that with my father, who, as an adult man, after my mom had passed away, had a couple doctors, both in the early 2000s, prescribing him narcotics, not knowing that they were both prescribing him narcotics, and led to him becoming addicted. And I knew that this was going on. He wasn't accepting that it was going on. So what eventually happened was he was at home. He had a pacemaker wire come loose, and he called vagal down and passed out. They brought him into the hospital, and they thought he had a stroke because within 24 hours he was completely irrational and confused, and to the point that they put him in an ICU. He was in 4-point restraints, and you know, I lived away at the time, and I was by phone telling them I actually think that my dad is having withdrawal symptoms. So I think I got there by day 3, and it was quite shocking to see your own father, who I've worked in hospitals basically since I was 18, and I've seen patients in withdrawal or patients with dementia, and he's in leather restraints, and he's trying to chew at his restraints because he's in fulminant withdrawal. And I walked out because I was only there for a few minutes, and it was agitating him more that I was there. So I was talking to the staff, and I'm like, let's give this a solid 2 weeks. And it took 10 days, and then he came out of it completely, like, no memory of what happened. And from that moment on, he never had another pill. And it was probably that planted the seed that I needed to get into this, because it hit so close to home for me as not only a person who takes care of people, but as a family member of somebody experiencing that. So that for me is kind of what drove me in the direction of how can we take care of people with chronic, in my dad's case, back pain, without giving them narcotics. And so then that was the evolution of how I got into the field. And now it's me continuing that process of looking at new and other ways of controlling pain and keeping people away from narcotics. Again, I don't want to say that they're a terrible thing. They do have their place, but in terms of everyday life, we have to separate the psychologic component from the pain component, because I may not be able to help with the psychological addiction, but I can certainly help with the pain addiction, and then from there, get their pain managed and help them then get in the direction of somebody to help them with their physical addiction to the medication.
All right, if you don't mind, we're going to ask a few questions. And
Fire away.
the first one, I think you've already answered a lot of, but how has the approach to pain management evolved in the past decade, especially with the opioid crisis and new treatment modalities?
So I think, obviously, alternative therapies. So over the last 10 years, it's what else can we do besides opioids? And the first and foremost problem, or the challenge with opioids, is they work really well for acute pain. That's part of the problem, is if you've been in pain and you're given a prescription for them, they work great. And so you're fighting against something that is actually solving a problem pretty well. And so that's part of the difficulty of removing that is I was given this bottle, I took some of these, the pain's gone, I don't see the problem here. And obviously, as Brian was saying, it's not an immediate thing. So the acute use of pain medicines, opioids, is still in every hospital every day. And if you're coming out of surgery, you're going to want something of that nature. So the alternative therapy line is over the last 10 years where everything has kind of shifted as to what else can we do, what else can we offer? Are there ways we can target nerves around the body, painful areas, painful backs, knees, hips, shoulders, things that we can do that don't go straight to those opioid receptors in the brain. So those receptors are the ones that cause the physical dependency. And if we can hit other areas around the body that don't hit that as well, then you're still having pain relief. It's just not, you're not getting the opioid side effects as well and the physical dependency. But they, in the acute phase, they work fantastic, and that's part of the challenge is you're fighting something that works pretty well.
I just had that experience. My aunt just had her knee done, and she said, I'm so uncomfortable. And my first comment was, stay ahead of the pain with the narcotics that the surgeon gave you. And she said, I'm really afraid, you know.
Yeah.
So people are, I think, frightened of taking, you know, narcotics and getting addicted and, you know, feeling that
For sure.
other feeling, right? She didn't want her knee pain, but she was very afraid of taking medication.
Well-
So we talked about the first few days, maybe you should take your narcotics,
Yes.
right?
So healthy fear, and I think that's a good thing to see now, where it's been in the public enough where now people say, I've seen enough things on this to know that if I rip through these, it's probably not a good thing. And if I end up not needing them, I should probably just get rid of these and not give them to my neighbor or whatever. So there's awareness enough now to where people have seen or they know someone that has struggled with it. So the caution is fine, but there is a place for that acute pain where they still fit in. And over time, you used to get a bottle of 100 pills after surgery. And then if you needed more, they give you more. So that has whittled down tremendously to, 10 or less. I mean, it's significantly less than it used to be. And that has changed over the last 10 years just by how everyone's been affected long-term from some of these medicines. So.
And that's governed a little bit, right? I mean,
Exactly.
certain procedures
Exactly.
will only allow that provider to write a certain amount of
Correct.
pills.
Yep.
So that is a little bit governed.
Right.
And I think your dad's problem of going to two different providers and getting two different prescriptions, that's been governed a little bit as well for the benefit of the patient.
Yeah, it was about 2017 that healthcare finally caught up with it and legislation passed. And basically, based on population, aliquots of narcotics are given to that area. And also there's the safe reporting. There's a lot of different ways of monitoring how much narcotic that a physician is prescribing. We see both sides of it. It's like, my doctor won't give me anything for pain. They won't give you anything for pain because they can't even prescribe you anything for pain. So those are the people that come in. So we see both sides of it. We see the people that come in immediately asking for pain pills, and they always get disappointed because I'm not going to give them any pain medications per se. I say pain medications. I'm going to tell them Tylenol arthritis is a great drug. Ibuprofen taken with food can be safe and not have problems. There's other things, meloxicam, other medications that are not narcotic based that can work just as well, but they have that dependency. And so it becomes our job to extrapolate from them that, yes, I understand that you think you need this, but just work with me on this. We have other means of treating your pain. And know that despite the fact that you want this, the alternative is you are going to continue the cycle of addiction, and ultimately it's going to shorten your lifespan, but more importantly, the quality of life that you think you have with it isn't there. And they don't see that. Right? They think that their life is so much better and so much fuller having that relief or that escape. Whereas I'm telling them is, let's first look, do you legitimately have pain? Because I guarantee you there is a backstory of pain that got most people addicted. And then I bring up my father again. He was filling a hole of the loss of my mom. So that was his coping mechanism, is he just wanted to cloud his mind so he didn't have to accept the loss of his wife.
All right, and I think I've seen that on the other side as a provider as well. So a friend went into the ER, kidney stone, very painful, right? And that was the age where the ER docs were, we're not going to give you anything. I mean, so there's that other side as well, right? That acute pain management really sometimes requires some medication. So what is the current evidence for alternative therapies like acupuncture, chiropractic care, massage, herbal remedies in pain management?
So individually, there is evidence for every single one of those to improve someone's pain status. Individual cases for individual patients. In any given day, we'll have patients that say, I tried this thing, be it water aerobics, and my pain was cut in half. Fantastic. I've been going to a chiropractor now, and my pain is gone from a 7 out of 10 to a 4 out of 10. Great. There's also the same patients that say, I tried that chiropractor, didn't work at all. So the alternative therapies, they become sort of a list that you do have to try several of them. And it's challenging to recommend certain things to certain patients, case by case basis. If I recommend to a 90-year-old patient of mine that she should be doing Tai Chi because the literature shows that it would really improve her back pain, it's a worthless mention, and it's a worthless interaction that probably the next thing I ask her to do, she's not going to do that either. So you have to know the specific audience and who's actually going to do what you may be recommending, because all of those individually have been shown to reduce pain. But if I know that you're not going to do these three, well, can I get you to walk around your yard? Can you be a little more active than you are now? If we cut your pain in half, could you walk your dog down the street and back more often? That sort of thing. So baby steps with some of these therapies, but they tend to snowball in that if somebody starts to feel better from going to a chiropractor, well, then they will walk around the block. So if you can add them a little bit at a time, but they all across the board have been shown to benefit someone. The question is who, and are they willing to try another one? Will you try something else? Will you try, the next thing on the list that we haven't tried yet? And generally speaking, yes, but if you just say try these 8 things, you'll probably have someone try 0 of them. So kind of ease your way into, but they all have been shown to be beneficial. So if somebody wants to pick one and do it, go for it.
So you talk about that at the pain clinic.
Oh, for sure.
What you're doing, as well as integrating some other.
Absolutely, and I say I am not in place. I am just another means of getting there. So I encourage the chiropractic care. I really think that just in itself, activity. If you have a purpose every day, the endorphins in our body is built with pain medication and mostly endorphins. And you talk about the runner's high. Why do they not hurt anymore? It's because our brains have the ability of medicating us, but we need to help facilitate that by doing things that we enjoy. And that's why I think that's the work that we do. Is it's functional health. It's can we get you back so that you're doing the things you enjoy. And I always have patients, well, I'm getting this procedure, and what can I do after? Go do whatever makes you happy. Who am I to tell you to go sit around and do nothing? First of all, I know for a fact that that's going to worsen your arthritis pain. Secondly, does that give you joy? And more often than not, the people are just looking for a way of getting resolution to their symptoms to the point, not of completion, but so that they can enjoy playing with their grandkids. I have young men that, have experience of hard labor for 20 years. I'm only 40. Why can't I get on the ground and play with my kid? Well, your back shot. And so let's look at turning off nerves at least and see if we can help you long term so that you go back to your life. And then when I do that, that's literally the most gratifying part of the job, is the people that are coming in and saying, oh, I'm able to play with my kids again. I'm able to do those things. But I also tell them, this is still not going to replicate or take the place of the benefits of chiropractic care, meditation, prayer, all of those things in unison, I think together work better than one individually.
Yeah, and I think we heard that in some of our stories this morning, right? Like just making a pledge to stop your addiction, or that didn't work for anyone, right? They all had good teamwork approaches and other people helping and good resources. So, so I'll switch gears a little bit. So what barriers, such as insurance coverage or provider training or stigma, limits our access to alternative pain therapies and even what you're doing as an alternative?
Stigma, very little on our front. I think patients are typically very interested in, what do you got? What can you offer? Let's try something because I'm sick of dealing with my pain. So very little on that front. The insurance front for us is always a struggle. And that's typically regional frustration. The procedure that you could potentially have next week in Iowa under the same insurance provider isn't covered in the state of Michigan. Why? I couldn't specifically tell you why, but there's many instances where what we used to do or still do, 6 months from now, we may not be able to do that the same way. So as things change, as insurances change, and there's so many different variations of insurance and what's covered and what's not, and you say Blue Cross, well, there's so many different variations of every single plan that the coordination of that and the constant changing of that it makes it challenging to know what and when we can offer, and the timing of it. The timing tends to drag on a bit. If somebody says, I'm in pain today, when can you fix this? Well, we got to check with your insurance, and so it can drag on to an uncomfortable amount of time where you go, we know what to do, we know how to do it, we can do it here, we have the time to do it, and we're not allowed to do it because we don't have an authorization for 2 weeks to do it. So we'll see you in 2 weeks. Sorry that you're hurting, but we'll see you in 2 weeks. So those are some of the frustrations with it that I can speak to.
I would say that there's a couple things. First of all, I would say the one barrier for us is we're a needle-based approach. The minute you start talking needles with people, they're like, nope, I'm out. But then when you talk about, can you, as a partner with me, tolerate me placing a needle into your body to alleviate your pain, that it may be that little burn of local anesthetic that hurts for that short period of time, but what if I told you you could have a year of 80% reduction in your pain? Eventually that conversation leads us to treatment. There are those people that are like, nope, I just want pills, and we say, we're sorry, we can't help you. We're glad to facilitate through your primary care or psychiatric care, but that's our mode. I would say in terms of not necessarily the barrier, but there is some hope in that recently the No Pain Act, which is a legislative measure through Congress, has increased access to pain care for people, and this was all on the downside of we screwed up and got too many people addicted to narcotics, and we need to offer these people who have chronic pain, who are addicted to narcotics because of pain, a solution. So the access, I think it's going to improve. It's just going to take time. And as you said, it is regional. We need a lot of support from our state representatives to push through further measures to open up access to a lot of these procedures that we can still do that most insurance companies will not allow us to do. But I have colleagues in other states that are doing them. So I would say that that's probably the bigger barrier. It's a state-by-state basis, and I think that becomes our job to pressure our legislators to help improve that.
So you answered the next question, which was, how can health systems and policymakers better support integrative pain management?
Yeah.
So,
Do you want to add anything?
Just like Brian said, the trumpeting of we have to do something else. We can't take away everyone's pain medicine avenue and just say, figure it out. So pain management, you need an alternative, and I think, be it a needle-based therapy, we offer an alternative to where people say there's no pills necessarily involved with this, and if we can treat it at the source, then it's a great alternative to the road we've already been down with a lot of pills. So.
I was gonna add, if you there's some really good, interesting graphs about narcotic overdoses and deaths in the United States. And you can actually see at 2017 a steep incline in the number of deaths, and that was coinciding with us decreasing the aliquots of narcotics. Well, how does that work? Well, then, guess what? It was heroin. And then heroin got too expensive because of demand, and then fentanyl fell in. So now fentanyl is as we've all heard, has taken the place of that. So I think that, you know, it seems like the government is working on that front, but definitely we took all the options of pain away for people in 2017, and all of the overdoses and deaths occurred. So now that's leveled off since about 23. And we're actually, I think, on a decline on that, and that is because that whole group of people that we got addicted to narcotics in the 90s, late 90s, early 2000s, many of them have passed away, but many of them are far enough removed from their narcotic usages, and they've sought out other ways of treating their pain. And I know that this is more geared towards the addiction component of things, but I think that we have to take blame. As healthcare as a whole has probably led us to this point, and it's now come to a point where we have options for people. It's just getting out in the community and letting them know that, you know, you don't have to suffer.
Yeah, I would agree. I think even dental care. I mean, how many times have you had a dental procedure and you leave with a little bottle and and you're thinking, well, maybe I'll just take some Motrin, like, and it takes away your pain just as effectively.
Sure.
So yeah, I think we were, as physicians, very quick to prescribe things, and I don't know, there were some papers about, you know, physicians not wanting to get phone calls about pain, right?
Sure.
Like, I don't want 3 phone calls on a Friday night when I operated Friday morning, because all of my patients are in pain, so I'll kind of pass out some narcotics and see how that goes, you know.
Yep.
And you know, I don't mean to blame healthcare in general, but we definitely have to take some responsibility for this problem. So what promising research or innovations in pain management are you most excited about? Is there anything new upcoming in your nerve blocks or?
So the nerve targeted therapies that we do now, so we have some of the just top of the line stuff for these procedures. So the locations around the body, primarily up and down the spine, but the knees, the shoulders, the hips. As more research has come out that people may benefit from other locations around the body, that's relatively new. That's been an option for people. So nerve targeted therapy, and it's something that you can redo. So if you have it done and the pain comes back years later, you can have it done again. It's not something that's a one-time situation where maybe it worked and we're done with that. So it's a continued treatment that I think is promising. There's a ton of regenerative therapy things that are kind of on the forefront right now, but we're just getting to that in being able to even digest what and where all of that works and how, and so that'll be in the next 5 or 10, I would think. It becomes pretty commonplace to slip in regenerative therapies certain places.
Great. Thank you. I appreciate that you've been able to kind of talk about, you know, integrating different kinds of care and the expectations for the patient. So I think that's important, you know, what they understand might happen or could happen to potentially increase their range of motion or things that they like to do. So yeah, very often I see people, you know, do you want to run a marathon? And no, I just want to sit on the floor with my grandchild, like you said. So appreciate it. So we're kind of out of time with my questions, but we do have some time for questions for Brian and Brian from the floor, if anybody has anything.
You have to give one of your mics up from the floor.
Oh. The voice from the back said, we're giving our mic to Bella.
Haunted or something. I don't.
Yeah, take mine. Thank you. Anyone? Oh, I see. Oh, no.
This has been very, sorry, I'll turn it on for you. So, let's see. Should be on. There we go. You just gotta put a little
So it's good to see this paradigm shift. I'm a retired RN, and early in the 1990s, in the hospital, it was the objective was not to have pain. And so we wanted to make sure that our patients didn't have any kind of pain at all. And so we would always, or we were taught to tell them, oh, as long as you've got pain, you can't become addicted. If you have legitimate pain, you can take this narcotic and your pain will go away. As soon as that pain level decreases, then you can not take that and you'll be fine. Well, that isn't really what happened, as we found out. And so it's nice to know that it's been recognized now that it is addictive, especially when you have pain and you don't want to keep taking it when you don't have pain. But all these other alternative methods are wonderful. And like you said, there's a number of different ways to help alleviate pain without taking addictive narcotics to do it.
Yeah, and I think, what I forgot to mention is I think that with the advent of AI and things like that, we're going to be able to do more mapping out, and genetic studies are another thing, is that there are people that have, like fibromyalgia, for instance. It got a bad name where people were, abusing that, but it actually is a clinical finding, and there's a way of identifying it. But those people have an upregulation of pain receptors, so they are experiencing more pain. And through genetic testing, we can now identify those people. And then there's other means of which then we can do a gene-specific treatment. We're like, oh, they're going to be a responder to NSAIDs, or they're going to be a responder to Tylenol. And then on top of that, they're going to be able to, in my opinion, be able to create more medications that don't hit the opioid receptors, that are able to target pain at its source better. That's the one area that we haven't had really great successes, is that you take a pain medication, for the most part, it works in your brain, whereas an NSAID, for instance, that actually goes to the location of the source of pain. You're spraying your ankle, it's actually working at your ankle. So there's more opportunities for growth there, and I do believe that this is where the advent of AI is in the scientific community is really going to help with things. So it's a good time to actually be, if you're going to have pain. And then the other thing to think about is that people need to understand that 90% of people over the age of 40 experience pain at some point in time in a given week, and that pain is a normal part of existence. Unfortunately, in many cases, at the age of 40, it's arthritis pain. And what Brian was alluding to is that we have these nerve-targeted therapies. Instead of medications, we use energy to turn off nerves. We can actually create a burn scar on a nerve that then breaks the cycle of that pain signal, and that nerve will eventually regenerate, but it takes anywhere from a year to 2 years for that to happen, and then we go back again with that energy and turn that nerve off. So that's an area that there is more growth for that. Other locations in the body will start using it. We're just not FDA approved to use it in outside of the places that we typically use it yet, but I do believe that that's going to happen.
Brian? Okay. Do patients need to be referred to your service? Can they? Okay, so it comes through your primary care. All right. And services are sometimes repeated, it sounds like, right? You might numb something or do a needle and
chronic pain. We definitely see patients potentially many times. Improvement can take a while. It can be as little as one treatment. It can be several. We have patients that have had success that we continue to see for years, because they say, this works for me, I'm coming back here.
And they don't need to have subsequent referrals. Once you're referred to us, become our patient. So then it's as if I'm your therapist. You just see us, or we take care of it.
Good, good. Well, thank you. That was really, I felt very comfortable too, like your explanations of all the different modalities, and the fact that if I was the patient, you would incorporate me into the plan goes a long way. So I appreciate it. And thank you for the services that you offer to the community. So now we're going to go